First off, good afternoon to everyone. My name is Mara, and I'm a communication specialist for IDF. And before we start today's session, I would like to go over a few reminders. First, please remember that each patient's treatment and condition is unique. The content presented in this session should not be used as a substitute for professional medical advice. And in all cases, patients and caregivers should consult their healthcare providers. So very important information to remember. Also, remember where you are in your journey of living with PI may differ from the person sitting next to you. The severity of PI can vary. And so now is my pleasure to welcome you to the WAS diagnosis specific session. So this session is going to be presented by Dr. Hans Ochs, and Dr. Ochs is a professor in the Department of Pediatrics at the University of Washington. He is also an attending physician at Seattle Children's Hospital and co-director of the Immunology Diagnostic Laboratory at Seattle Children's Research. So please join me in welcoming Dr. Ochs.
Okay, so that was a case some 60, 70 years ago when Wiskott saw this one-year-old boy who had bruises. And he also showed prolonged bleeding after circumcision. He had bloody diarrhea, which started right shortly after birth. He had recurrent otitis, mucoid drainage, and eczema started at 3 months of age. And it responded to steroid cream. That's not what Wiskott had. He had no steroid cream. And the family history was negative. He had 2 healthy sisters. And at that time, a definite test was done. We can still do it, but Wiskott did it and found that this patient had very low platelet numbers and small platelets. So that's Wiskott to the left side. At the time when he was chairman of pediatrics, and interestingly, he described that disease and then he completely forgot about it and had never seen a patient after his first 2 families. On the right side is Aldrich, who rediscovered the disease after the war. This Wiskott before the war and Aldrich after the war, and he recognized that it was X-linked. So now we call it Wiskott and Aldrich syndrome, and also sometimes X-linked thrombocytopenia. And the difference between the two, the classic Wiskott-Aldrich and the X-linked thrombocytopenia, is the fact that in classic Wiskott, in addition to having this X-linked inheritance, and in addition to having thrombocytopenia with small platelets and a little bit of eczema, which can be an XLT, the classic Wiskotts have also serious bloody diarrhea, recurrent infections due to an immune defect. They can develop autoimmunity, they can develop malignancies, and at least the classic Wiskotts are now treated either with stem cell transplantation or bone marrow transplantation, or possibly with gene therapy. So here you can see on the left side platelets of the Wasp patients, and if you point out these small platelets out in the middle compared with on the right side, where there are many more of these blue spots and all of them are large. And I want to point out that Wiskotts can also have some large platelets, or a few. And that's why it's so difficult to measure the platelet size in a normal lab, because the counter counts only the big ones. And so the Wiskott-Aldrich platelets, as they are reported from the lab, are often not so small as they should be. So that was Wiskott's original design of these children. There were 3 boys, and they all had eczema and colitis, and that's how he wrote it down. And that's essentially how these patients had presented to him. And all of them end here at the right side, they end with death. So they lived for about a year and a half, and then they died of their disease. And he describes here, he makes, he doesn't have a photograph. So he shows the distribution of the eczema. It's all over the place. So maybe a little more in the face. And that's how he wrote that's the original from his first paper, which was published in 1936, I think, or 1937. That's how he described it in German, and then submitted it and was published in a pediatric journal in Germany. That shows the pedigree of one family. And can you see in the bottom, there are 3 males that are in black. They are the infected, and all the girls were normal. But if you look here at top, you see he was interested in the father, not the mother. So if you just go up here, that is the father up there. And again, the father, the great-father, the grandfather, though he didn't recognize that it was X-linked. But he recognized that it was familial. So he called it familial ITP. It said, you know, it's not ITP, it's something familial. And that's where he stopped describing it. And that's just a few of our patients here. Up there, those are the lymphocyte numbers. And the hatched area is a normal range. And you can see all these boys, they start normal. And then over a period of 6 to 8 years, on the bottom, you can see they all fall below the lower range of normal. But here, that AS patient who is still in the normal, he has had ITP, he has had X-linked thrombocytopenia, and did well. You know, he just took antibiotics because they tore his spleen out because they thought he had ITP. But unfortunately, when he turned 28, he developed leukemia, in spite of the fact that he had a mild disease. So this is a little difficult, but if you look at the yellow line up on top, that's the immune response of a group of normal, that's a mean. And in the bottom, you can see, on weeks, you can see a primary immunization. That's on the left side. That's when they got the first immunization, right at the left side, primary. And then when it says secondary, they got a booster. And then when it says tertiary, a 3, they got the 3rd booster. And you can see this is a log scale. So the normal controls, they increased and they stay up. Whereas these 2 patients, a brother and a nephew, they cannot remember. They go down within 4 weeks to nothing. And then they make a little antibody and they go down to nothing. And then the 3rd, again, a little bit. And then you can look up there in parentheses percentage. That's percent IgG. So after 3 immunization on top, the normals make 90% IgG, whereas the patients with Wiskott never make any IgG. And that's why they need gamma globulin infusions. Now, X-linked thrombocytopenia, they are in between. And I have seen some that have normal antibody responses, but they are much better in terms of their immune deficiency. So this is just to give you a view of that gene. Of course, the gene is not a line, but I wanted to show you that the gene product, the Wasp protein, has different domains. They are shown here. And that's why it makes this so interesting, and shows that there are different functions of the Wasp protein, which depends on where the mutations are. They may have different diseases and different phenotypes. So this is more a schematic show that there are different domains that are all important for the function of Wasp. So here I wanted to give you a sense of what a immunologist is doing. So once, in this case, there is a 6-year-old boy, and he, at 9 months of age, he was diagnosed with Wiskott-Aldrich, and he was found to have a stop codon. And so this is the DNA, and you can see at this position, 753, he switched from a G to an A, and that made it a stop codon. So that W252 is an amino acid, and instead of the amino acid, it becomes a stop codon. And you can, when you go to the right and you look at the wild type, maybe you can show up here the black arrow up here. There is a G, a black G up there, and it becomes a green A. And that made it from, if you read this, underlined, it's TGG, it makes it a TGA. And the TGA is a universal stop codon. And they are necessary because, you know, when the gene is being read, it has to stop at certain, normally. But if it happens in the middle of the gene, then you have a stop codon, and the patient has severe Wiskott. So when we try to find out if the protein is there, this Wasp protein. So because it's a stop codon, it stops the transcription from the DNA to the protein. And here you see the normal control. That's what we call a flow. So with a monoclonal antibody specific for the Wiskott-Aldrich protein, that's a non-specific antibody. And if you use a specific antibody, you move this to the right. And the log scale, there's a lot of protein. And we look at lymphocytes, lymphocyte subsets. But then at this patient, where there is a stop codon, you don't see that red peak on the right side of the blue non-specific peak. So it's even smaller. So this patient has no protein whatsoever. And that would be a patient who has a severe mutation with a stop codon up there, and he has no protein expression. And that's what you hear sometimes, you know, the doctors are interested, is there any protein or is there no protein? And after transplantation or gene therapy, is there protein or not? That's a test we do. So that's an example of X-linked congenital ITP. That's what it was usually called. And it is actually a Wiskott, an X-linked thrombocytopenia, but they were recognized as an entity and were called X-linked congenital ITP. And there is an interesting family. So here you have the index case on the bottom. Know that right on the bottom, and it says the mutation, that's the amino acid, and that's the nucleotide, and that A56V is the amino acid. It changes the amino acid. And then there was an astute pediatrician that, you know, this patient has thrombocytopenia at birth, and they are small. Let's see if he has Wiskott. And they sent me blood, and so he had this mutation. Then we asked, the mother was perfectly normal, but she said, you know, my dad, he always had thrombocytopenia. He had always ITP. And we found in the 59-year-old grandfather of this patient, we found the same mutation. So he also had X-linked thrombocytopenia, but he was not diagnosed until 59 because what he had was thrombocytopenia. And then they said, well, the great-grandmother of this little boy, she was in a nursing home at age 87, and she always had problems with bleeding. And she had the same mutation, as her son, her granddaughter, and great-grandson. Why did she bleed? Because when we looked at the X chromosome, she used mainly, you know, each woman has 2 X chromosomes, and as a carrier female for Wiskott, there's one normal and one abnormal. But she only used predominantly the abnormal X chromosome. So she was essentially like her son and like her great-grandson, was affected with practically X-linked thrombocytopenia. All right, those are 2 brothers with X-linked thrombocytopenia, and they are very, very healthy. They have a mutation, amino acid substitution. All of them have low platelet count. And this one has very mild eczema. You can see it. This one had no eczema whatsoever, and they had normal immune response. So a very mild form of Wiskott, which we call X-linked thrombocytopenia. And you can identify them predominantly by finding the mutation. So that was a study which was done by Dr. Michael Albert from Munich. It was an international study with something like 170 patients with X-linked thrombocytopenia. And if you look, this is a normal survival, 60 to 75, and it's essentially like the normal male population in Germany. So they have a very good survival. But if you look at events, disease events, they start very early, and by the time they are 30, 50% had serious problems. And they are infections, they can develop autoimmunity, they can develop malignancy, and they can have premature death, like here. So it's not to say that we can forget about X-linked thrombocytopenia because they have such a good survival, but there are problems along the way. So splenectomy in XLT, because if you take in XLT the spleen out, then their platelet numbers go up, they have no bleeding anymore, they have a significant increase, however, in severe infections, because the spleen is important to keep sepsis out of an individual. And so I know it's very highly significant. And that's where our patient with XLT who were transplanted for leukemia, they didn't put him on prophylactic antibiotics, because once you do a splenectomy, you have to put these patients on prophylactic antibiotics all their life. He didn't get it, and he developed sepsis a year after successful transplantation, and died of sepsis. So you need prophylaxis even after transplantation. If you had your spleen removed for XLT or Wiskott-Aldrich, you need to be on antibiotic prophylaxis. So just to show you on the molecular level, these up here are XLT patients on the top. It says XLT. And you see all these mutations they have are little round spots, most of them. And they are point mutations, missense mutations. These are mild mutations. When you look at the Wiskotts, all these spots here, they are nonsense mutations or insertions or frame shifts. So those are mutations that are severe and stop the production of the Wasp protein. Whereas in XLT, the protein is usually there, but it doesn't work as well. So based on the mutation, we can pretty much predict, not 100%, but we can say, that this patient will fall in the category of X-linked thrombocytopenia, or this patient with this mutation and this defect in protein will fall into the classic Wiskott-Aldrich population. So once we looked at our cohort, which was about 240, about half of those which we did molecular analysis and careful clinical phenotype analysis and gene analysis, half of them had just XLT, and the other half had classic Wiskott-Aldrich. And then Gigi Notarangelo had two families with intermittent thrombocytopenia. So they had at times thrombocytopenia, and at times they were normal. And so we call them intermittent X-linked thrombocytopenia phenotype. And so they could go down to 50,000, and then another time they are 300,000. And there was no real history of bleeding, major bleeding. They had no infections, just like normal children. They had no autoimmune disease. They have no malignancy. And so they are very mild XLTs, if you wish. And here you can see up in the dark area, that's normal range. And there are two of those patients. Sometimes they were in normal range, and then sometimes they dropped down. They could drop down to 50,000. And we just tell them don't play football. But otherwise, there is no need for splenectomy. There is no need for bone marrow transplantation. So now I wanted to point out one area of this protein. It's called GBD because it results in an unusual clinical phenotype. If there is a mutation in GBD, you can see it on that line. There's a PH and then the GBD. Then you get not Wiskott, you get a neutropenia, a congenital neutropenia. And what happens is that's the area GBD, that's the area where the mutation is. And normally, if a cell is not activated, the Wiskott-Aldrich protein is self-inhibiting. It's inhibited. It folds in like this. And there is a an area where when a other protein, it's called the CD42-GDP, if that is phosphorylated or dephosphorylated, it either goes away and then the protein can self-inhibit, or it opens it up. So you have a helper protein that opens up the Wasp protein, and now when it's on the bottom, when it's all opened up, it interacts with another protein and it's causing what's called actin polymerization. And that's very important because that's the way a cell moves. So the Wasp protein is very important for cell movement. And if you have a mutation here, then it cannot, in that L270, for instance, then it cannot fold in and inhibit. It's always open and it's always active. And for one reason or another, it causes congenital neutropenia. So that is, if you model the protein, that's how the protein looks like. And here on the yellow thing, you can see it sort of folds in. That's at this position. And if there's a mutation in the L270, then it cannot form this inhibition loop. It's open up, and that's X-linked neutropenia. So that is called congenital X-linked neutropenia. It starts at birth. It arrests the myeloid cells, which develop into neutrophils. And the infections these patients have are not characteristic for Wiskott. They are characteristic for patients who have no neutrophils. The platelets are completely normal in size and number. There is no autoimmune disorder. There was one case of a lymphoma. And interestingly, there are some members with the same mutation. They don't have a disease. And that's a little iffy. We don't know why that happens. But certainly these patients exist. And so I talked to you, if you look at the top, I talked to you about X-linked thrombocytopenia, XLT, classic Wiskott-Aldrich, and then X-linked neutropenia at the right side, XLN. And then the IXLT would be the intermittent X-linked neutropenia. And we have a scoring system, and I don't want to go into detail, but as more severe the patient is, as more points the patient gets. So if you have classic Wiskott-Aldrich and the score of 3, 4, and 5, you have all these problems. You have, of course, you have thrombocytopenia, small platelets, eczema, immunodeficiency, infectious disease, autoimmune disease. But if you have intermittent X-linked XLT on the left side, you just have you have a score less than 1, maybe thrombocytopenia and small platelets. But then in XLT, you have a score of 1 or 2, and you have a little more. And then if you go to the right side, the X-linked neutropenia, they only have congenital neutropenia. So that's where we come up with scores. And sometimes, people who think about transplantation, if a patient has only a score of less than 1 or maybe 2, they are very hesitant to do bone marrow transplantation. But if you have a score of 3, 4, 5, you need to be transplanted sooner or later. So that is, again, the scores I already explained to you. In the interest of time, let's just go to the next. So what are the consequences of mutations in that protein, that WAS protein? So the protein can be absent or truncated, and then we call it a nonsense mutation. And that is due to the lesions in that gene, insertions, and splice site mutations, and that causes classic Wasp. And they have high incidence of autoimmunity. They can develop malignancies. If it is a missense mutation, then the protein is mutated, but it's present. In contrast to in the severe, where it's absent or truncated. So if the protein is mutated but present, like in missense mutation, so they still have the protein, then you have X-linked thrombocytopenia or intermittent X-linked thrombocytopenia. And these patients have a low incidence of autoimmunity and a low incidence of malignancy. And then you have that loss of cell inhibition of the Wasp protein, as I explained to you, like this mutation, L270P. Then you have congenital X-linked neutropenia. So the Wasp mutations, if you know, I showed you about half are XLT, the other half are classic Wiskott. If you look at the mutations, the majority have either a missense mutation or a splice site mutation or a nonsense mutation or insertion, and some are very complex. And those who have a missense mutation, they're usually X-linked thrombocytopenia, mild. And some of the splice site mutations are also mild. So if you look at the mutation that cause Wiskott and that cause X-linked thrombocytopenia, in yellow is a missense mutation. So they have mainly missense mutation and some splice site mutations. Usually they splice in frame, so they are mild splice site mutations or mild deletions, whereas in classic Wiskott, they have deletions, they have big splice site mutations, they have nonsense mutations in red, and they have missense, a few have missense mutations in yellow. So looking at the mutation, you can sort of pretty much guess if they fall into the X-linked thrombocytopenia category or in the classic Wiskott-Aldrich. So what is the role of Wasp? And so over the year, we found a lot of reasons why that is so important. So it allows signaling from the surface of the cell to go inside of the cell, because Wasp in small proportion can sit on the outside, and it forms what we call synapse, where cells talk to each other and signal. So as I mentioned already, that activation or inactivation is very important for this actin polymerization, which allows the cell to move. Cell locomotion, cell trafficking, it's very important. Intracellular signaling is involved, and that is that immune synapse formation. So if you have a mutation in Wasp, you also have problems with regulatory T cells and with NK cells, natural killer cells, because the cells cannot interact with each other. That's shown here, the NK cells, CD8 cells. So that's why they have autoimmune disease and develop cancer. So these functions are all important for what we call the adaptive immune system, which depends on T cells and B cells, as well as what we call innate immunity, which is not so much on cells, but it's like complement and neutrophils. So it plays a very important role in the way we defend ourselves against microorganisms, but also against autoimmune disease and against malignancies. So very crucial protein. The other interesting thing, that protein is only expressed by blood cells. Most of our genes are expressed in many other cells, but the Wasp protein is very specific for blood cells, and that's why bone marrow transplantation works so well, and gene therapy. Just know that is, I talked about some of those cytotoxic cells. They need Wasp to interact with target tumor cells. The regulatory T cells are very important to prevent autoimmune disease, and they need Wasp to talk with other cells. So it's crucial not only for the antibody producing cells, but for all the cells we have in the blood. So what can we do if we make the diagnosis? So it's important to make the diagnosis as early as possible. So boys are the ones. They bleed into the skin, and if they get circumcised, they bleed for a while. They have bloody diarrhea, they have eczema, they develop infections. And then this is a clinical diagnosis. Once you suspect, then you have to confirm the diagnosis by looking at the protein and by doing gene analysis. And then, you need genetic counseling. One has to identify the carriers. One can now perform prenatal diagnosis if you have the mutation. And of course, then it's important to see an expert, and explore all the options and Google it. There's a lot of information on Google, and then go for it. Either, if we decide together with the doctors to do hematopoietic stem cell transplantation, do it as early as possible, or gene therapy when it comes online. So what do we do else? Platelet transfusions, we don't do that because the platelets only have a short half-life and they sensitize the patient, so no platelet transfusion. But a helmet is okay. The platelets survive only 4 days, and transplanters don't like it because you get sensitized, so they may reject the graft. You can get hepatitis from these platelet transfusions. It's logistically very challenging. You use it only if a patient with Wiskott or XLT has brain bleeding, brain hemorrhage, or if it's a severe GI bleeding and you cannot stop it, or other bleeding that you cannot stop. Or sometimes, if they need surgery, you may just give them platelets during surgery and put them on a helmet when they start to crawl. And of course, don't let them play football. So splenectomy, people have that tried out because it works like a charm. But you are damned if you do and you're damned if you don't. Why? Because if you don't do it, the patient may die of a bleed because when you take the spleen out, the numbers of platelets and the size of the platelets increases and protects the patient from bleeding. But the controversy is that within a few months, usually after splenectomy without antibody prophylaxis, they develop sepsis, meningitis, and it can be lethal. Splenectomy has no effect on autoimmunity or cancer, so it doesn't prevent autoimmunity or cancer. So we do not recommend splenectomy in Wiskott and also not in X-linked thrombocytopenia. There are some centers where they may recommend it in X-linked thrombocytopenia, but I think it's too dangerous. So this is a boy which we diagnosed early, and that is he just got a sister, and the sister turned out to be a match, and that was before he got transplanted. He's cured. He's now in college and a bodybuilder, perfectly fine. So when do you transplant? If you have classic Wiskott-Aldrich with severe clinical phenotypes, you need to have a donor, which is no longer so important because we can do what's called a Haplo Transplant. So we have tricks to find a donor for essentially every patient. A matched sibling would be the best. Haplo-identical parents can be used. Cord blood can be used. We like to have the patient without acute or chronic infections when we transplant. So that's why it's better to do it early before they get chronic infection. And, the parents, we talk to them about the risk, the patients accept the risk. And there is more benefit if we do a myeloablative regimen, but not complete. So we do now a sort of reduced intensity preparation, which is tolerated very well. And in the last few years, the survival chance of transplant is over 90%. Now, gene therapy has been very successful in mouse models, and it really depends on what we call a vector. So a number of vectors have been designed and used. One of them was retroviral vectors, and as Sumadi knows, the retroviral vector use in Wiskott was a disaster. Essentially, all of those patients developed leukemia. So it worked. They were corrected, but it was the wrong vector, and it caused the some of the cells to become leukemic cells. Now we use lentiviral vectors, and they have been quite successfully used for almost 6-7 years now. And they do well, except the platelets are still sort of on the lower side. But the patients do well. They are off IVIG. They don't need antibiotics. Of course, we don't know how long this lasts, but we can take the patient's cells again and repeat the process. The problem is cost. And I think that's why the company who has taken this up has put a stop on it, because they would charge about $1 million for gene therapy, whereas bone marrow transplantation, in some places you get it for $100,000, and if you go, for instance, to India, you get it for $40,000. So gene therapy at the present time is not available. It's still experimental, and I think the companies are now trying to figure out how can they reduce the cost, how can they make it better than bone marrow transplantation. So that was Wiskott when they had a little birthday party in 1978 in Germany. And at that meeting, he stood up and he said, you tell me I'm famous because of this disease, Wiskott, but I have never seen another patient. I have never written about it, but I think in America they found some patient again, and he was referring to Aldrich. And he essentially said, I was just damn lucky that I was prepared to do a little study, and I published it, and it got forgotten, and it was rediscovered. And of course, he died before we had the gene identified. And I remember when we found the gene, I went to Aldrich. He was retired, and I visited him, and I told him about it. I wanted to have a picture from him, and he was so happy that that the gene for this disease was finally discovered. So that is in Seattle when we have no smog and when we have sunshine in the spring and everything is blooming, and we don't have to avoid crowds. So I wanted to congratulate IDF for having set up this very interesting colloquium and meeting, and it looks fine. So the only thing what we next time have to do is find a way so that the presenter can actually move a cursor and can show the details. So thank you very much, and I think we are right on time. We have 15 minutes.
Yes, that was perfectly timed, actually. So at this point, we're going to move to the Q&A session. So if you have questions, if you could submit them to the chat, we will start doing that now. Okay, so our first question is, has there ever been a known Wasp patient who developed autoimmunity but not malignancy, indicating the rank 5 might need division?
Yeah, so they are not linked together. They're only increased in patients with classic Wiskott with a mutation that results in no protein. And it's just like hit and miss. So they may develop both, or more often it's just one or the other. And I have to say, these autoimmune diseases and malignancy don't start as infants or children, but as older they get, we all have a chance to get autoimmune disease over time, and it's more often in older. And it's the same thing in Wiskott, except that the frequency is much higher. So yeah, and we give them a score of 5 if they have either a malignancy or an autoimmunity.
Right. And the next question we have is, what is the risk of developing hepatitis B from transfusion? Are platelet donors not screened for hepatitis?
Yeah, they are, but theoretically, and the most frequent is actually hepatitis C, and they are screened, and we can screen them either by antibody to these viruses or by PCR, looking actually for the virus. But if a patient was screened 3 weeks ago, and then he gives platelets 3 weeks later. Theoretically, you know, he could have picked up hepatitis. So there is a window of vulnerability, and those donors that are used for gamma globulin, no, many of them, they come to these plasmapheresis places. They give their plasma, and then they are tested, and the plasma is stored until they come back the next time, you know, 3 weeks, 4 weeks later, and they are tested again. And if they are test negative for all these viruses, including HIV, then they use the previous one, the plasma that was collected 3 weeks earlier. And the one that being taken at the time when they are tested, that's stored for another 3 weeks. So, but these platelets, you know, you cannot store them. So, you know, it's not a big problem, but it could be. And so, you know, that's one reason why we don't recommend platelets. But that's not the main reason why we don't recommend platelets for Wiskott.
And then our next question is, can you speak to any data indicating the advantages or not of transplants using post-transplant cyclophosphamide, if I'm pronouncing that correctly, versus the traditional techniques or methods?
Well, we use post-transplant cyclophosphamide only in one setting, and that is if we don't find a matched sibling or a completely matched donor or a highly matched cord blood, then we use what we call a Haplo transplant, and that's a parent. And Haplo means half. So the parent is the parent of this child is half identical. The other half comes from the, let's say, we take the father, the other half comes from the mother. So that would cause, in Wiskott, would cause graft versus host disease. So we have to do something to prevent this, and that is this post-transplant cyclophosphamide therapy, which is being given on day 3, 4, and 5 after transplant. And what the idea is that you give these incompatible Haplo transplant, and then these cells from the donor, they have a population that would attack the recipient. And when these cells go into the recipient, they get activated and they start to divide. And then you put the poison in. Cyclophosphamide is a cytotoxic drug. You know, it's used for malignancies. So then you knock out those aggressive donor cells that would cause graft versus host disease, and that works quite well. And it's relatively cheap. It's not dangerous. We don't use the same doses as we use for cancer, but we don't know the long term. So I think we try to avoid this if it's not necessary. So if you have a matched donor or a matched sibling, we don't use cyclophosphamide. Now in Moscow, they do it in all their patients. They give a post-transplant cyclophosphamide, or they do the other way we can do these not matched transplants, these haplos, is by removing these aggressive cells, not by a drug, but before the bone marrow is given, there are columns, there are ways to remove subsets of T cell. They are called T cell receptor alpha beta cells. And we can remove them and then give the benign, you know, the emasculated, if you wish, cell population to the recipient, and then they don't develop graft versus host disease. But that T cell receptor alpha beta is a little more complicated, it's more expensive, but it may be in the long run safer. But one could do this but if it's a well-matched donor, it's not necessary, because we can handle mild graft versus host disease with less dangerous drugs.
Yeah, and our next question is, how do we know when a patient has ITP? When does a positive antibody to platelets mean ITP? Is it a clinical diagnosis or lab diagnosis?
So ITP, no, ITP means idiopathic thrombocytopenia. That means we don't know why they had ITP. And so 50 years or more, maybe 60 years, 70 years, somebody, a physician, he thought, there could be, maybe there's something in the plasma of these patients with ITP. They were not Wiskott and they were not X-linked thrombocytopenia. And he took plasma from a patient and injected in himself, and he almost died because his platelets got to pot. And he had to wait until this antibody from this ITP patient was metabolized until his own platelets came back. So then they figured out that it is an autoimmune disease and that you have these autoantibodies. Now, if you have autoimmune disease that causes hemolytic anemia, you can easily find the antibody. With platelets, it's not so easy. So we usually don't look for these platelets, but if a person has ITP and not Wiskott and not X-linked thrombocytopenia, it's almost 100%. Know if it's acquired, that this is antibody mediated. And we treat these patients even without finding the antibody. We just treat them with either drugs or manipulations to remove these autoantibodies. And no, we are pretty good in reversing this with rituximab or with plasmapheresis, or there's a new drug now that one can use to deplete these autoantibodies. So it is, it's always, and the interesting thing is patients with Wiskott or X-linked thrombocytopenia can develop ITP. And so then their platelets really go all the way down to the bottom. And they need to be treated for ITP on top of having low platelet numbers because they have Wiskott. And those are really emergencies to transplant immediately.
Yeah, and then our next question is, why is alpha beta T cell depletion using a machine not used for all patients?
Well, as I alluded to, first of all, it's expensive. And depletion of these population, they are not all bad players. They have some important physiologic role. So if you can get away without depleting it, you save money. You save a step, which could actually damage a little bit the bone marrow that you have harvested because it has to go through this machine. And we don't really know the long effect. And so if we don't need it, then we decided, at least here in Seattle, not to deplete. Again, in Moscow, some patients, they use this cyclophosphamide treatment, but alternative, they use this machine that depletes alpha beta cells. And the outcomes are not different from ours because, survival, if you have survival of 90 to 100%, if you make further improvement, it doesn't statistically show up very easily.
Yeah, and then our next question is, will wasp boys grow out of nosebleeds? If so, around what age? And what is recommended other than transfusions to stop them?
So there are cases where spleens are not successfully removed, and it could be, it's really not that they regrow. There's a leftover in there, and that may start. But if you get it out completely, I think that's it. And I think once you have a splenectomy and the surgeon has done a good job, he permanently, that boy has no spleen and needs to be covered with antibiotics. I don't think they need IVIG. A classic Wiskott may, but an X-linked thrombocytopenic patients may not need IVIG, but certainly prophylactic antibiotics, and need to know that if he gets a fever, he has to go to the emergency room and get a blood culture, and then maybe add more potent intravenous antibiotics.
And our next question is, between GT and lentivirus and Halo, do you have a preference? What would you recommend?
Between, what was that?
They said HPLO, not Halo. Sorry. So let me reread the question. Between GT with lentivirus and HPLO, do you have a preference? And what would you recommend?
You mean for gene therapy? Is that the question?
They said haploidentical transplant. Maybe they. Oh, I'm sorry. Yeah, that's all the information they gave. We do have enough. If you want to provide more information, you can submit that to Ask IDF, and we can answer that at another time.
Is it related to haploidentical transplant, or?
Yes, that's what they're saying. They said for an EWAS boy without a match, would you recommend a haplo transplant or GT?
Well, at the present time, gene therapy is not available in this country. And I don't know, the only other place where they were very active with gene therapy is Milano. But I think they also don't accept. So at the present time, if it's a classic Wiskott-Aldrich, I would say, let's do what's available. And it would, if there is no matched donor, then go to a Haplo. And Haplos do quite well. And I think you can do this even in developing countries. They do Haplo all the time now. So it's not a big deal.
Right.
And I would not wait for gene therapy if it's really a classic Wiskott-Aldrich that needs to be done. Okay.
And our next question is, how many transfusions are considered too many?
Transfusions of platelets?
They did not specify. They just said how many transfusions. I guess, is there ever a case where transfusions could be considered too many? You get too many?
Well, I think if it's platelet transfusions, I think one is already too many, unless it's really needed. So if platelets are being given for low platelet counts, that's a no-no. But if the patient really bleeds into the brain or has a severe bowel bleeding, that has to be stopped. And so you weigh the benefit against the potential problem. And if you have a severe brain bleed, that can be deadly. You have to stop this. But just because the CBC comes back and now he has only 5,000 platelets, and you want to give platelets, that is not indicated.
Right, and that was actually perfect timing because we have maybe 45 seconds left. So if anyone has any further questions, they can submit their question to Ask IDF, which you just go on your IDF account and submit it through there. But thank you so much, Dr. Ochs, for joining us, and thank you everyone for participating. And the next session is the keynote session, so we hope to see you guys there. But thank you everyone for joining us today.
Okay, I had actually expected a question about COVID.
Oh yeah.
And just to cut the chase, they do very well. So don't worry about COVID.
Yeah, that's good to hear. Yeah, and there's also people in the chat typing, thank you so much, Dr. Ochs. And again, thank you so much for, providing all this helpful information.
Okay, good.
So everyone have a great rest of the day.
All right, thank you.